and I hope you did enjoy it. We want to start the next session on time because the previous session we started a bit late, which meant we ran almost late. And we do want to keep to times. So please, if everybody who's doing talks can keep to their time as well. And even a bit shorter to allow people time to ask you questions if necessary. So I'm going to start off with Dr. Rachel Pawson. She is she's a consultant hematologist, and she's the medical director for the British Bone Marrow Registry and for the NHS Cord Blood Bank. Her talk is Biovigilance, Lessons Learned from WMDAs, Serious Events and Reaction Reports. I think that most of the clinicians especially might find this interesting, because we do report any serious event to WMDA, and there's a committee that looks at everything and gives feedback, but I'm sure Rachel's going to tell you all about that. Thank you very much, Rachel.
Thank you. Thank you very much. Again, I'm a bit older than Rihanna, so I've got 2 pairs of glasses. I have to check the right one before I start. So, thank you very much to Jane and Charlotte and the other organisers for inviting me to talk today. It's a privilege to be in Cape Town. I have to say what I've seen of the winter here so far is better than the British summer has been, albeit apparently we're having a mini heat wave back in Oxford that I'm missing, but I'm still glad to be here. So I'm very grateful for the opportunity to tell you a bit more about the WMDA Serious Product Events and Adverse Reactions Committee. It is a mouthful, which is why we abbreviate it to SPEAR. And the topic I was given was really lessons learnt, but I thought I'd start off by giving you a bit of background about the SPEAR reporting system and how it works. The lessons that we've learnt are inevitably going to be just a snapshot of what the community has gained from the SPEAR reporting system, because that has been going for 21 years, a long time. I've only been involved for the last 5, 6 or so, quarter of the lifespan of the SPEAR reporting group, so it's really a snapshot of things that we have learnt. But to start off, I'm going to give you a bit of background about what the SPEAR reporting system is and fundamentally why we do it. And really, it's all about protecting donors from harm. So the quote, "Do no harm," looking to where it actually originates from, it goes back to a long time ago, 400 BC. Hippocrates, a Greek philosopher and physician, came up with this statement, which still, the last few words of this statement here still summarize, the ethical principles that guide us in medicine now as they did, in 400 BC. And interesting, when I was sort of Googling where this, what the actual origination of this statement was, this quote, it's not from the Hippocratic Oath, it's from a different document, his Treatise of the Epidemics. So one of the lessons learnt along the way, as an incidental, is about Hippocrates. But while Googling this, 2 other things come up. The Google search algorithm ahead of Hippocrates, what a surprise. These are 2 bestsellers that have been in the top 10 UK literature for recently. And I'm sure Hippocrates was a bestseller in his day, but not at the moment. These 2 are up there. So the book on the left, A Skilled Surgeon Makes the Best Murderer, is probably not quite the topic we want to discuss today. But the book on the right is quite an interesting book, basically an autobiography from quite an eminent British neurosurgeon who describes in quite some detail, the grappling of, if you're trying to help patients, inevitably you're going to cause some harm, and how you get your head around that and manage that. And I think that sort of segues into what the SPEAR reporting system is trying to do. We know inevitably we're going to cause harm to some recipients and donors along the way, but we want to monitor this and see if anything can be done to prevent harm, which is what we're trying to do. So the SPEAR reporting system was set up trying to capture adverse events and reactions in related and unrelated donors. As I say, it's been going for 21 years now, and it's become a requirement for a WMDA accreditation. The original systems were pieces of paper being faxed around the world, and now happily we have an online reporting tool, which I'm sure is a lot slicker. The definitions we use, there's nothing earth-shattering about the definitions. We're following the EU definitions of a serious adverse event and a serious adverse reaction shown on the right of the slide. The fundamental difference being the reaction actually where there is damage caused of some sort, as opposed to risk of damage and harm in the event classification. And really in our context, serious adverse reactions can either be harm to donor or harm to recipient, and the sort of definitions are on that slide. They're also available on the website. Risk of harm, an adverse event when a problem could have caused harm but didn't have in this context. And this reporting system is really set up we don't really want well-known side effects, a bit of a headache with GCSF, etc. We're not expecting that to be reported, the things that are mild. And what does the committee do with them at the other end? How are these reports handled once they've been submitted? So just to mention that sometimes reports are submitted via a parent organisation, but once they're received by the WMDA, a medical advisor reviews the reports and might send questions back to the reporter if there's missing information or a bit more is needed, accuracy checks, etc. And then the medical advisor will pass the report on to committee members. And they will be asked to review and they can accept a report themselves, or if they think they're missing information, more questions back to the reporter potentially, or if there are uncertainties, they can bring the case to a committee meeting. The committee meets monthly, and then the committee there will discuss the nuances of how they accept the report or not, particularly looking at imputability, that's been assigned by the reporter. Do we agree? Severity, and checking the ICD coding, etc. What are the outputs of this committee? So we like to think that we provide educational materials along the way as interesting things come in, that we can either post things in stem cell matters, hold occasional webinars, and put things, send out individual email reports as well. We can look for trends in similar cases. If you can come to us and say, oh, we've had a donor that this has happened, is there something you know about? How often does this happen? We can search the database and look for stuff like that. We can make rapid alerts if things look more serious. So, to let the community know about things, and I'll come to a couple of rapid alerts later on. We can suggest to the standards committee, oh, we think there's a gap here. Can you look at this for us, please? And we put out an annual report, which you may or may not have seen. There's a web link there to show you where it is on the WMDA website, reviewing a whole year's worth of adverse events at the same time. So that's the outputs of the committee. And what have we learned from this? So, as I said before, slightly random selection of things that I think are interesting for the stem cell community in general, and a few asides of things that I've learned personally along the way. Fundamentally, I think this is the most important thing. I think stem cell donation is pretty safe. We wouldn't all be in this room together if it wasn't. So it's pretty safe. And I'm sure you're going to see this slide quite a lot over the next few days. The Global Trends Report showing the number of stem cell donations per year internationally. And you probably can't, is it big enough to see on the right-hand side, 2023 data, there's about 23,500 adult stem cell donations being shipped internationally, with cords that's close to 26,000 donations going around the world. And in this context, again, it doesn't show very well. On the right-hand side, this is the number of SPEAR reports the committee have accepted. Right-hand side, 413 in the blue column. So in a context of that many shipments, that's not very much. 2022, we've got a bit more granularity of that data. So slightly fewer shipments. 56% of these coming from WMDA accredited registries who should be reporting their adverse events. So that means just over 13,000 shipments we'd expect to get reporting on, and 282 reports. So that's roughly 1 in 50, not that common. And of those things that are reported, I'll come to show you, I think most of those are not serious. So the pie chart on the left shows you the types of reports. So the blue, 85% of the reports that we get are harm to donor. The bright red is risk of harm, and harm to recipient we get very few reports of. Of the harm to donor, the breakdown is about 50-50 split consistently between short and long-term harm, grey, short-term, less than 6 months after donation, yellow, longer-term harm. So, and then the right-hand chart, I don't think I've got a pointer. Oh, have I got a pointer? Oh, I have. Oh, how exciting. This is a breakdown of the harm to donor reports in 2022. And the things that are classed as more severe, so CTC grade 3 and above, are largely within these classifications of donors to have been diagnosed with non-hematological malignancy and autoimmune diseases, mainly more than 6 months after donation, where we think the imputability is extremely, extremely unlikely to be related to their stem cell donation. The majority of things that are happening earlier and the imputability more likely to be related to donation are at the milder end of the scale. But there are still some serious adverse events. Happily, donor deaths are extremely rare. This slide shows a few years worth of the rapid alerts that the committee have issued, and of those, only 2 have been deaths of unrelated donors, the only 2 directly related deaths of donors that we're aware of in the unrelated setting. The bottom one was a donor that very sadly died of a complication of a central line from pneumothorax, and more recently, a donor who died as a complication of the sedation and anesthesia related to the bone marrow donation rather than the actual donation itself, I suppose. But there are some other things that we see coming into the committee that are also serious. And a case last year came in which we put an alert out about a donor. This is case 3 shown on the slide here, of a male donor who developed a subdural hemorrhage just as he was coming off the machine at the end of a first day apheresis procedure, bad headache, hypertension, happily was sent to an emergency department very rapidly and made a very good recovery after this neurosurgical procedure. We looked back through the database and found another couple of cases that were not dissimilar. And then earlier this year, there was another case of a young donor with no obvious predisposing factors, no history of head injury, that was reported to have a subdural 48 hours after a PBSC donation. And in total, amongst reports, and we found a total of 8 cases in unrelated donors, all but one, a subdural, one was a subarachnoid. Some of these were onsetting sort of a few weeks after donation, but 5 of these were, quite temporally closely linked to the PBSC donation. And just to give the context, this is 8 cases over 16 years of reporting, and at least 80,000 PBSC donations in this context. But it's very difficult. We've talked, myself and a few colleagues internationally have talked to neurosurgeons and neurologists, agonizing over, is this a causal thing that we're seeing? What could the pathophysiology be? And there is no clear pathophysiological link. Only one of these donors has had a platelet count of less than 100. It was 41 post-donation, possibly. But, acute spontaneous subdural hemorrhages are very rare, and it can be quite difficult to get detailed information from reporting registries. Could this be a chronic subdural where there's been a bleed, etc.? So the association, there looks like these cases are temporarily associated, but is this causation? It is not clear. So that makes it quite difficult how to handle and to make recommendations if we want to do them. So the alert that we put out last year was really about informing donors, and particularly about monitoring donors post-donation, either while they're still in the apheresis unit, when they go home, do they know that they should be reporting bad headaches? And for them and for registries, apheresis units, what do you do? Do you know your emergency escape route? Who do you call if you've got a donor going off in front of you? I think that's the most important sort of recommendation that came out of these alerts. And I know some registries internationally, depending on their legislation, are considering adding cerebral hemorrhage to their donor information. It appears to be vanishingly rare, but we also ask you to report near misses. Now, why? Is it just extra work? I think this case illustrates that this can be important and allow us to produce guidance that hopefully will stop harm in the future. So this is a case reported last year of a donor who tested negative for HIV at medical, but on the day of donation had a further IDM testing and was found to be confirmed HIV positive by both serology and NAT. Luckily, it was a planned cryopreservation. The patient hadn't been conditioned, so the transplant centre didn't use the cells. But it was fortuitous that the transplant centre did day of donation testing, and that was just because the samples they wanted for previous testing hadn't got to the laboratory for whatever reason. So, that really was a close call for the recipient. In this particular case, it's hard to pinpoint exactly what the mode of transmission for this donor was, but they did declare some high-risk behaviours between the medical and donation. And they'd also had some PrEP usage in the past. So we sent out a rapid communication last year, which was basically just reinforcing the message to go to donors about declaring high-risk behaviour. I think we're familiar with asking at medical about it, but the key, another key time point is after the medical. If the donor has any exposures, high-risk behaviours, that please can they inform the registry as soon as possible so that there's a chance to do something, either cancel, talk to the transplant centre, extra testing, etc. And so, I think we've had a few donors reporting after medical such behaviours after this guidance. Anyway, so hopefully that will avoid transmissions. Another example, expect the unexpected. There are some weird things that come in as reports, and we were talking about disasters earlier, fire, flood, etc., how we're going to manage these. So we had a case earlier this year, last year, made the headlines, made the German tabloid press before it hit the SPEAR reporting system, which I guess is probably not too surprising. And the middle picture is the Google translation of the left headline, so I hope it's okay. Any Germans in the room can correct it. But quite an interesting story of a courier had just got onto train in Germany, just before the automatic doors shut. Somebody took the product away from him, the door shut, and the courier could do nothing, basically. Later, the empty bag, transport bag, was found outside the station without the product. Happily, PBSC donation, and the donor was available to collect the next day, so the patient got their transplant. When we looked into the database, this wasn't the first time. I was surprised. I thought it was probably the first time. But 2015, a similar story of a bone marrow product being stolen. The graft was actually found in another city. Temperature logging was all fine. The bag hadn't been opened, so the transplant went ahead, etc. And there's actually a third case, which was more a case of a courier forgetting a product on a train rather than actually being stolen. But I thought it was quite interesting, and personal learning here. I have to thank Dr. Mengling from DKMS, TILO, for this slide. Who knew the differences between train stations across Europe? So apparently, Germany, bottom bullet point here, doesn't generally on its stations have any physical or technical measures where people, for accessing, getting onto trains, etc. And maybe that's a contributing factor. Is it coincidence that these cases have been in Germany? I don't know. But in terms of recommendations, to couriers, be very careful if you're travelling by any train, maybe particularly in Germany. And if you're on a train in particular, again, stay alert, stay awake. Falling asleep with the product on an aircraft is a very different thing from falling asleep with the product on a train or bus. So courier training, I think, is really important here. Manual control of the product, don't put it on the rack, keep it close to your body, etc. So a recommendation that came out of the committee. And then the last lesson, I think is also useful. So TILO in particular has pulled out a lot of data looking at registries that report adverse events, at least one adverse event a year. How many do they report? And come up with these figures. So we would expect, in terms of harm to donor only reports, harm to donor within 6 months of donation, the expected reporting rate is 1 report for every 100 shipments that your registry makes. If you are doing more, if you include late harm to donors, risk of harm, etc., harm to recipient, we'd expect a few more, sort of in the order of 1 to 2 per 100 shipments. So food for thought, if your registry is reporting more than that, doesn't necessarily mean you've got a problem, but it's worth looking at it. Are you selecting different donors from other people? Transport, your couriers falling asleep on trains. If you're submitting less than that, maybe there are things that would be interesting to report or useful to report that are not being reported. And the SPEAR committee has got an open session at the meeting on Saturday just to plug that. If you're not sure what should be reported, shouldn't, please come along, and there's a Q&A session there where you can ask the team. So I'm going to finish with this summary slide, a bit of revision for the lessons learnt. I think the most reassuring thing about our reporting system is, generally stem cell donation is very, very safe. Rare cases like the subdural, just to emphasise again, they are vanishingly rare, but we're obviously monitoring closely, but it can be very difficult to assess the imputability. And that makes making recommendations for donor selection very difficult. Please keep reporting near misses, risk of harm cases. There are always going to be unexpected things coming along. Another example of this would be one of our stem cell labs in England recently had to shut overnight because of reinforced aerated concrete. So there's a big scandal going on in the UK about low quality concrete that was used for a lot of public buildings in the 70s and is failing. And health and safety are coming around inspecting public buildings. Overnight, one stem cell laboratory was told they could not go into their cryovac room. End of. Patient conditioned in the hospital, stem cell scientists thinking, I need to go and get the stem cells, being told you cannot go into that room, etc. So there will be unexpected things coming along. And then to finish, the expected reporting rates, and as I say, please do come to the session on Saturday if you want to. And just a couple of thank you slides, just to thank the committee members. As you can see, we're a multinational team. Everybody's doing this in their spare time, so very grateful. Can be quite arduous to look at the reports, and particularly Thilo, Ifka, and Tigran for slides and support. Thank you.
I think you've allowed some time for questions. Okay. So perhaps we should do some questions now, because I think there were some very interesting events that were mentioned. There's one down there. Can we get some mics? Can everybody hear me? Okay. You probably can hear me.
What about the NGS abnormality we detect in patient after transplantation?
Genetic abnormalities?
Yes.
Yes. So there is going to be a new reporting system for those. Because we want to know about them, but the plan is the medical committee is going to set up a different way of reporting them, which hopefully will go live. I don't think we've got a timescale soon. I think in the meantime, you can send them in as SPEAR reports, and we will sort of put them aside. Hopefully they can go into the new system at some point.
Thank you so much. Have a seat here, and if more questions come up at the end. So the next presentation is something a little bit different. It's ABO incompatibility in bone marrow stem cell transplants, a blood transfusion perspective, and it is being presented by Tanya Glatt. She's a hematopathologist at SANBUS, or the South African National Blood Service, and oversees the specialized therapeutic services, and is also an honorary lecturer at the University of Witwatersrand in the Department of Hematology and Immunology. And they have recently received your JC accreditation, so I think we can give her and SANBUS a little clap for that. And if you come up and do it.
Okay, good afternoon, everybody. Thank you to the organisers for having me, and this is a topic that I'm very passionate about, so thank you for including this in the program. So we're going to be talking about ABO-incompatible stem cell transplants. we're going to define and classify them, and then look at special considerations from the perspective of a registry, clinical facility, the collection facility, the processing facility, as well as the transfusion service, and then look specifically at blood product support and outcome measures. So as you know, anybody who receives a blood product, that blood product must be ABO compatible, but stem cells are different because they don't express ABO antigens on them, and therefore they don't actually need to be ABO matched. The literature says about up to 50% of matched unrelated transplants are ABO mismatched, and about 15% of match-related transplants are ABO mismatched. We were always told that ABO mismatched transplants don't have an overall worse survival, but do they? We will look at that. But everybody agrees that ABO incompatible stem cell transplants definitely have specific considerations. Although the stem cells themselves don't have ABO and AB antigens on them, they are suspended or admixed with other blood with red cells, platelets, and plasma, and specific patients may have specific considerations in terms of that. I don't know. RT, please. Cool, thank you. Okay. So there are three types of ABO-compatible transplants: a major, a minor, and a bidirectional. A major is when the recipient has antibodies to the donor red cells. A minor is when the donor has antibodies to the recipient red cells. And a bidirectional is both a major and a minor. Okay, so just very basics of the ABO blood group system. You can't see the whole slide. Okay, you'll just have to listen to my voice. But if you are blood group A, you have A antigens on your red cell, and you lack B antigens, so therefore you have anti-B antibodies in your serum. If you're blood group B, you have B antigens on your red cell, you lack the A antigen, so you have anti-A antibodies in your serum. And if you're blood group AB, you have both A and B antigens, and therefore you have neither anti-A or anti-B. And if you blood group O, you have neither the A or the B antigen, so you have both anti-A and anti-B in your serum. These antibodies are naturally occurring, so you will have these antibodies if you lack the antigen. You don't have to be exposed to that antigen to make these antibodies. And we see these within the first 6 months of life. Okay. So for example, a major mismatch would be if your recipient is blood group O and your donor is blood group A. So your recipient has anti-A antibodies to the donor red cells. Okay, a minor mismatch would be, for example, if your recipient is blood group A and your donor is blood group O, so your donor lacks the A antigen and will have anti-A in their plasma. And then bidirectional, if your donor's A, he'll have anti-B, and the recipient's B, she'll have anti-A, or vice versa. Okay, so we'll start with our major ABO mismatch. And the risks here are really hemolysis, okay, which can either be at the time of the transplant or a little bit later, so acute or delayed, and the acute can be very severe, okay? It's like giving what you would never, ever, ever give in transfusion medicine, an ABO-incompatible red cell unit, okay? So you guys can see it, but not me. It's okay. Sorry. It's okay. Okay. Delayed red blood cell engraftment. So this is where your neutrophils and your platelets engraft beautifully. So the transplant physician is very happy because the transplant's gone well, but the patient's HB is so low and requires recurrent transfusions and can't be discharged yet. And then pure red cell aplasia, which is very rare. What's important is that these clinical manifestations depend on two things. They depend on the amount of red cells that the patient is receiving in the graft and the amount of antibodies, or the strength of the antibodies, so what we call the antibody titer of the patient. Okay, what's very important also is the source of the product. So if you have a bone marrow collection, there are a lot of red cells in there. These days, apheresis collections have very, very, very few red cells, but a bone marrow collection, by definition, it can have up to a unit of red cells. Okay, so can you imagine giving a whole unit of ABO-incompatible red cells to your patient? You cannot do that. Okay, so how do we manage a major ABO-incompatible transplant? We cannot prevent it, okay? The only thing we can do is preempt it, okay? So know that it's going to happen. And the two things we need to know is, okay, firstly, that it is an ABO-incompatible transplant, and then once we know that, we need to know the antibody titer of the patient, so the strength of their antibodies, and the amount of red blood cells in the graft that they're going to receive. So what we say in general is that if the titer level of the patient is less, 1 in 32 or less, or if the volume of red cells in the graft is, in our center, we use a standard of less than 20 mils. Okay, in pediatrics, we say up to 0.5 mils per kilo. Some centers use up to 40 mils. Then we say that you may not require any intervention. So we know that the patient has antibodies to donor red cells, and we know that the patient is going to get those red cells in the graft, but because there are so few antibodies or because there's so few red cells, we are not really worried, okay? Or the risks of complications are much lower. If, however, your titer level is higher, so 64 and above, or you have more than 20 mils of red cells, then you must consider further management. Okay, so either you can remove the red cells from the graft, or you can remove the antibodies from the patient. So from the patient with plasma exchange or immunoadsorption prior to the transplant. What's very important to remember always is that when you remove red cells, you remove stem cells. You will always lose some stem cells, so you have to make you have to weigh up the risks and benefits depending on the yield and the stem cell yield of the product that you have. Okay. So just one slide on what we actually do with antibody titer testing, okay? So say, for example, your patient is blood group O, and they're receiving an A graft, so they have anti-A antibodies, and you want to know the strength of the strength of their antibodies, okay? So you submit a sample to the lab, and we take that serum where the anti-A antibodies are sitting, and we have the first test tube, which is neat, and then we mix 100 microliters of that, of the patient's serum with 100 microliters of normal saline, so that's a 1 in 2 dilution. We then take 100 microliters of that, and we dilute it with 100 microliters of normal saline, so now we've got a 1 in 4 dilution. Take 100 microliters of that, put it in another test tube with 100 microliters of normal saline. Okay, so you get the picture. So each test tube has less and less and less antibodies. Okay, now we want to know the strength of these anti-A antibodies, so we take red cells which have A antigens on them, we mix them together. Okay, and we look for agglutination. So what we actually looking for is this picture here. Okay, your patient's antibodies and those red cells. And the first, you can see they're agglutinating because the patient's got antibodies, and the first tube where there's no agglutination, that's the titer level that we say that the patient has. Okay, so obviously the higher the titer, the higher the strength of their antibodies. Okay, so that's what we're reporting when we report titers. Okay, so now we move on to minor ABO-incompatible transplants. So this is when your recipient has antibodies, where your donor has antibodies for your recipient red cells. Okay, and remember, these antibodies obviously sit in the plasma, and every single stem cell source has plasma in it. Stem cells are always suspended in plasma, but specifically your cord blood, your bone marrow products can have up to 1,500 mils of plasma. Okay. I can't change the slide because there is no slide for me to change. Okay. So complications of a minor ABO-incompatible transplant is that hemolysis of the recipient red cells, so the antibodies in the plasma of the graft to the red cells of the patient, and this can be acute or delayed. Okay. The management, again, we cannot prevent this, but we can preempt this. Okay, so firstly knowing that it is a minor mismatch, and then also knowing the titer of the antibodies of the donor. Okay, so if it's less than 1 in 128, we usually don't do anything about it. If it's more than 256, we always consider plasma reduction. And again, when you remove plasma, you remove stem cells. Okay, and then very importantly in a minor mismatch from a clinical perspective is that you must know this patient is a minor ABO mismatch, and therefore I must monitor this patient for clinical and lab signs of hemolysis post-transplant. So the acute hemolysis is very rare. We only really see that if there's a large volume, if the patient is getting a large volume of plasma compared to their plasma volume. But delayed hemolysis we do see, and if you don't look for it, you'll miss it. You just think that the red cell engraftment is delayed, or they've got some infection, or etc. But unless you must have a high index of suspicion of delayed red cell engraftment in your minor ABO, or hemolysis in your minor ABO-incompatible transplants. This table actually just summarizes everything I've said. So it defines a major, minor, and bidirectional. It tells you which antibodies to which red cells, and the potential adverse consequences, and then what you can do to manage it. Okay, so the next topic we're going on to is blood product support in ABO-incompatible stem cell transplants. And the next two slides are from my colleague in the Netherlands, Hans Freiling, and he put together these two slides, which basically are the rules of ABO transfusion. Okay, so this is for red cells. One second, let's not get confused. So this is for red cells. Okay, so when you want to transfuse red cells. So across is your donor blood group, and down is your patient blood group, and green is compatible, and red is incompatible. Okay, so when you're transfusing red cells, you're worried about antibodies in your patient to the antigens on the donor red cells. Okay, so you can see here, if your donor is blood group O, they have neither the A or the B antigen. Okay, so therefore it can actually be given to any blood group. Okay, and that's what we say is the ABO universal donor, because regardless of what ABO antibodies are in the patient, they won't react with the antigen, the AB antigens on the patient red cells. Okay, the second slide, this is for plasma products. Okay, so this is different. So if your patient, and again it's the same, that it shows donor across and patient down, green is compatible and red is incompatible. So if the donor is blood group AB, it means their red cells have A and B antigens, and their plasma has neither anti-A or anti-B. And when we're giving plasma, we're worried about antibodies in your plasma reacting with your patient red cells. So if we give AB plasma, okay, that patient, it means the patient is blood group AB, they have neither anti-A or anti-B, and therefore those antibodies in that plasma are not going to react with the patient red cells. And that's how we say for plasma, AB is like our universal donor. Okay. So, blood product support in stem cell transplants is divided into three phases: phase 1, phase 2, phase 3. Phase 1 is up until the day that you get your transplant. Okay. Phase 2 is from the time you get your transplant, okay, up until the time that your red cells are totally donor. Okay. So phase 2 is the complicated part. This is the part where you have some of your own red cells as well as some of the donor red cells. So there hasn't been full donor engraftment, okay? And then phase 3, when you're completely donor, okay? So you've completely converted to donor red cells. The red cells have engrafted. The confusing part here is actually, if you really want to know when your patient has moved from phase 2 to phase 3, that is the testing that's done in the blood bank, where we say, okay, well then a negative DAT, but that your forward grouping looks like donor only and your reverse group looks like donor only. There's no mixed fields. And also the patient can't have been transfused red cells recently as well, because that may alter the picture. Okay, so the reason why it's divided up into three different phases is because blood product support in these three different phases is different. Phase 1 is easy. You give recipient compatible blood products. Phase 3 is easy because you're completely donor now, so you give donor compatible blood products. Phase 2 is very confusing. Okay, so the EBMT came out with guidelines originally that said for red cells you give blood group O, and for plasma and platelets you give blood group AB. So basically what they just did was they looked at this universal donor here, and it's cut off on the slide, the universal donor for red cells and for plasma and platelets, and that was their rules. So then the NHS-BT came out with other guidelines where they said, yes, that's correct, but what happens if we don't have those products available? And there are other products which we could also use. Okay, so they said that for major, remember we said major is when the recipient is antibody to the donor's red cells. So if you give recipient-type red cells, those are the same red cells as the recipient, and therefore the antibodies that the recipient has is not going to react to those red cells. Okay, for minor, they said the same thing. So the problem with minor is that the donor has antibodies. So if you give donor-type red cells, then those antibodies are not going to react with the donor-type red cells. Okay, and with bidirectional, they say exactly this universal donor thing, that you give group O red cells, and platelets and FFPs you give AB. Okay, so this table shows us the exact same thing. It gives you the list of the blood groups of the recipient and the donor and the three different phases. You can see phase 1 is always recipient type, phase 3 is always donor type, and then phase 1, it depends, it shows you for each blood group. Okay, this is a simplified one as well, which shows you the exact same thing, but you can see for each blood group, for your major, you always give recipient type red cells, for your minor, you give donor type red cells, and for your major, donor FFPs and platelets, and for your minor, recipient type FFPs and platelets. What is very important is that any center that's performing allogeneic stem cell transplants will be performing ABO-incompatible allogeneic stem cell transplants, and therefore must have procedures or must have a protocol for their doctors of what of blood product supports for these patients. So just on principle, that slide that I showed you about red cell compatibility. Okay, so red cell transfusions must always be ABO compatible. That first red and green slide, you always need to follow that for red cells. Okay, obviously you don't want hemolysis. For plasma, you follow your guidelines. In South Africa, the clinical guidelines for transfusion medicine say that if you're using 4 or more units of FFPs, they must be ABO compatible. Okay, and that's the second slide I showed you of the green and red, that you should be using compatible. Less than that, it does not necessarily need to be compatible. Platelets is like a whole talk on its own, and I could talk about platelets for entire half an hour, and Prof. Seftel will be speaking next on platelets specifically. But we do know, okay, so platelets don't have RH antigens on them, which we haven't covered at all, but they do have ABO antigens on them, but only up to about 14 to 17% of them have strong expression of ABO antigens on them. So maybe you want ABO compatible platelets because maybe the patients would increment better or require less platelet transfusions, but ABO incompatible platelet transfusion, you're not worried about hemolysis. Okay, so with red cell transfusion, ABO incompatible, that's a no-go because you don't want hemolysis. Whereas with platelets, it would be a different pathophysiology that you would be concerned about. And what's also important to know is what your platelets are suspended in. So often platelets are suspended in platelet additive solution, which don't actually have any plasma in it, so they don't have any ABO antibodies in that plasma, so you're not giving patients antibodies. And with apheresis platelets and even pooled filtered platelets, there are negligible red cells there. Okay, so that's why the risk of hemolysis is not there. Okay, so now we move on to outcomes of ABO-incompatible stem cell transplants. Many studies have looked at if there's a difference in survival or difference in outcomes in ABO-compatible versus ABO-compatible transplants, and for as many studies that say that there is a difference, there are studies to show that there is no difference. Okay, so this table summarizes a couple of studies where they looked at both outcomes, survival outcomes, as well as GVHD risk, and you can see there a lot of them show no difference, and then some of them show that there is a difference in survival outcome. And I can't move my slide because I don't have a slide to move. Okay, thank you. So this study, I just added here the conclusion because I think it's very important. So it says, of course, ABO-compatible donors are optimal. However, ABO incompatibility generally exerts less impact on outcome than other donor-recipient relationships. Overall, major ABO mismatch does not seem to have a consistent effect on other outcomes, other major outcomes after allogeneic transplants, such as incidence of acute or chronic GVHD, relapse rate, and overall survival. Okay, so that was that study. This was another study that looked at about 400 adult patients with a mix of diagnoses, so acute leukemias, lymphomas, MDS, aplastic anemia, and myeloma. And it looked at survival outcomes, engraftment, and blood products. Okay, and it compared ABO compatible to ABO incompatible, and it found no difference in survival outcomes, no difference of engraftment to neutrophils and platelets, but definitely, sorry about that, delayed reticulocyte engraftment in your major mismatch, and then as well as increased red blood product, red cell requirements in your major ABO mismatch, but no effect on survival. Then another study, which thanks to Prof. Seftel for sharing this one with me, is almost 5,000 patients. However, all of these patients had acute leukemia, okay? And they compared ABO match with ABO mismatched, and they found that major mismatch was associated with worse overall survival, inferior platelet engraftment, and higher primary graft failure. But acute and chronic GVHD were not significantly associated with ABO status, and their conclusion was that donor-recipient ABO status is independently associated with survival in acute leukemia, and that you should consider ABO status in donor selection algorithms and its impact in acute leukemia. Okay, but really, in terms of the outcome measures, there's such a heterogeneity in the underlying disease, the patient age, the variations in transplant practice, even whether you're going to red cell reduce or plasma reduce the patient or the graft and the GVHD prophylaxis, that this all adds to the complexity of interpreting outcome results and making conclusive findings about the outcome of ABO incompatible versus ABO compatible stem cell transplants. Okay. So what is the SANBIS experience? So in SANBIS, we have a collection and processing facility, and I don't know this slide off by heart, so we'll have to look. So this was over a 2-year period where we had 53 allogeneic grafts. We had 45% were match-related donors, 51% were matched unrelated donors, and less than 4% haploidentical. 29 grafts were ABO mismatched, so this is 55%, so slightly higher than what we see in the literature. 8 were major, 16 were minor, and 5 were a bidirectional mismatch. You can see the indications at the bottom, the majority of them for acute leukemias. And we had none of our ABO incompatible recipients had primary graft failure. We had 1 ABO matched that had primary graft failure. 1 ABO incompatible recipient had a delayed platelet engraftment. This was a minor mismatch versus 3 of our ABO matched. We are still looking at important outcome measures, 1-year mortality, graft versus host disease, and relapse rates, as well as blood product requirements with our clinical facilities. Okay, so in summary, ABO incompatibility is definitely not a contraindication to stem cell transplant. The allogeneic stem cell transplant program in South Africa is increasing, specifically because of our matched unrelated donors, and thank you to the registries for that. And so we are likely going to just see an increase in ABO incompatible transplants. What's very important is that we need to identify and classify these very early. A product should not be arriving in a processing facility, and that is the first time that you realize that you've got an ABO mismatch between your donor and your recipient. So the testing, the classification, and the further workup, whether it's titer testing in your patient or your donor or both, should be a routine part of your patient and donor workup. And it really needs to be a team effort, collaboration between your registry in the middle, your clinical unit, your collection facility, your processing facility, and your blood transfusion facility. So we can really have spectacular achievements in our ABO incompatible transplants, but they really need some unspectacular preparation to get there. Thank you very much, everybody.
I think we'll do some questions first.
Okay.
There is time for a few questions. If anybody has got a question, can we take some mics around, please? Can we dim the big lights because it's difficult to see the audience?
Hi, Hong Yang from the Australian Registry. I don't know if you have this in South Africa, but in Australia we have a program where we immunise Rh-negative donors to make anti-D immunoglobulin. And I've been asked a couple of times, what implications does that have for the donor? As if they're also a bone marrow registered donor. Is that going to exclude them or have an effect?
Yeah, thank you. So that's a very good question. We haven't yet had a donor who is Rh negative who does have antibodies. It's not an absolute exclusion criteria. However, just like the ABO mismatch, you would get a minor or a major mismatch, okay? And in that case, it would be a minor mismatch. And what's really important there is that you've not titer levels, but really it's with the blood product support as well. So it wouldn't exclude it for if your recipient is Rh negative, that would be great. If your recipient is Rh positive, it would really complicate matters. And if the clinician can find another donor, that would be a best bet. As I say, we haven't had that. Maybe we don't have enough donors to have that, to be fortunate enough to have that problem yet. Yeah.
Hi, Paul Johnson from Amphi Nolan. I actually have a poster out there calling for the extended rhesus typing. What would be your opinion on that? Like, is that something you'd like to see done up front for donors?
I would like to see extended RH typing for blood donors and for patients that are chronically transfused, like sickle and thal patients, and we don't yet have that in South Africa. That's really something that we're working towards. It would be great, but we don't even have it in our blood donors, but yeah.
Okay, thank you.
Thank you.
Okay, I think that we can end there, and Tanya, if you can stay on stage, if we have any time at the end, and we have more questions, we can ask them. I'd like to ask the next speaker to please come up. It's Dr. Matthew Seftel. He's currently the department head for hematology and oncology at Cancer Care, Manitoba, and the section of the hematology oncology department of internal medicine at the University of Manitoba, where he holds an associate professorship. He has supervised, and we know this, numerous research projects and postgraduate theses, and received a number of teaching and service awards. In the same sort of theme that Tanya was presenting in, he will move into HLAs, not just for transplanters, it's platelet transfusions and refractoriness. So he's going to talk to us about that. Thank you, Matthew.
Thank you very much, everyone. Apologies that I wasn't at the most recent sessions because I was at the WMDA board meeting, which is contemporaneous to this meeting, so I apologize for my sudden entry, and I'll have to leave after my session as well, and that means that all the difficult questions will be deflected to Dr. Glatt, who's an actual transfusion specialist, so please stay. So I'm a clinical transplanter who is, I have a medical director role with Canadian Blood Services, which is the national blood transfusion service in Canada. And because of my role there, I think the assumption was that those are Canadian Blood Services. And if I know about transplantation, then I probably know a little bit about platelet transfusion. And that's true. And I thought that because you've just heard about red cells and ABO compatibility in the world of transplantation, talking about platelets in the world of transplantation and complex hematological malignancy dovetails well with the most recent talk that you've heard, so they go nicely in partnership. So that's why I thought I would talk about platelets. The other thing is that this whole session I see was entitled Unpacking Transplantation, and transplantation cannot happen successfully without transfusion support. So I'll move ahead from there. For those of you who at EHA, the European Hematology Association, you might have gone to the Prado gallery where many of Goya's paintings are shown, and this is one of them, which depicts somebody sleeping, a reasonable person sleeping, and is bothered by terrible nightmares. And so, one of the nightmares about giving a platelet transfusion is that they don't respond to the platelet transfusion. So this is my little reference to EHA and platelets, is that it can be for HLA reasons, it can be for non-immune reasons. HLA, I think, is an owl, and non-immune is a bat. Anyway, just a reference to a hematology conference that happened. So I work for Canadian Blood Services, that's my disclosure. So you probably heard from Tanya, but I'll just summarize that in the world of transplantation, which I've abbreviated to HCT there are some specific issues that I think are relevant to a good outcome for all aspects of transplantation. Some relate to red cells, particularly iron overload. You've heard about ABO incompatibility. Circulatory failure from all of the volume from these products is an issue. Relevant to my talk is platelet refractoriness. There are some other issues as well: transfusion-transmitted infections, transfusion-associated graft versus host disease, all important, but I thought I would talk a little bit more about the platelets. So in terms of objectives, time permitting, I'll talk about some recent updates relevant to transfusion practice. I'll run through some of the causes and patterns of platelet transfusion refractoriness, and try to tie that into some recent technological advances in the world of platelet transfusions. And then I'll touch on the diagnosis and management of alloimmune platelet refractoriness. And through that, I'll actually explain to you how this actually has affected my career from when I was a trainee. So quite a long time. So firstly, the trends in platelet transfusion practice. So courtesy of the CIBMTR, and I see my colleagues from CIBMTR have just entered the room, so I'm giving them full credit for this lovely slide to tell you that transplantation, as we know it, has been around for decades, but it's become very, very commonplace, both autologous and allogeneic. The trends are increasing. And a transplantation more or less cannot happen without an expected period of cytopenias for which inevitably platelet transfusion support is needed for most patients. In other words, it's the exception of a patient who does not need either red cell or platelet transfusion support. And for those with acute leukemia, they would have needed plenty of blood products prior to their transplant as well. So built into this, baked into this, is transfusion support. And you think, well, there's all these new technologies that are going to do away with transplantation. Well, CAR T is one of them. And again, it's very hard to get around a successful CAR T procedure without transfusion support. There's a long period of cytopenias that ensue after infusion of CAR T cells. So with this, again, baked in is transfusion support. And again, courtesy of the CIBMTR, these are US statistics, but I wanted to try to illustrate to you the causes of death, which are often early in the transplant course after an allogeneic transplant. And I'll bring to your attention in blue hemorrhage, which is there, 5% in children prior to day 100, and also 3% in adults. Prior to day 100. If you were to have shown the same pie graph for transplants that were happening in the 80s, the proportion of patients who were dying of hemorrhage would have been higher because we now have much more successful hemostatic interventions, including ready availability of mostly safe platelets. So just again as a reminder to say, you can't do a transplant with all this good supportive care, including transfusion support. So I'll start with a question. This may be very obvious to the clinicians here. Is what is the typical threshold for prophylactic platelet transfusions in stable transplant patients or those with hematological malignancies, so acute leukemia being an example? Is it less than 10? Is it less than 10 as long as you're using tranexamic acid? Is it less than 20? Or should you simply not use platelets? Should you not use them prophylactically? Only give if the patient were to have bleeding. It's a little bit of a large room to have a hands up and a Q&A kind of session. So maybe I'll just let that sink in and you can think about what you would do, whether you'd use prophylactic approaches or therapeutic approaches. But I said that I would highlight some recent studies. Now, this is not that recent, but a very important study that came out of the UK about a decade ago that asked that question, do you need to really give prophylactic platelet transfusions to these sorts of patients, transplants in hematological malignancy, because platelets are associated with risk, they're quite hard to procure, and they're expensive. And so this was a very well-designed randomized trial in hematologic malignancy and transplant patients that randomized people to the standard prophylactic measure of platelet transfusions when platelets were 10 or less, to those who did not get prophylactic platelets. They only got platelets if there were signs of bleeding in a patient. And it was designed as a non-inferiority study, but that study failed to meet the non-inferiority requirements of the trial because there did appear to be more bleeding in those that were not receiving prophylaxis. In other words, there does appear to be some sort of threshold below which, in these quite sick patients, bleeding will ensue without prophylactic patients. So this didn't change practice. And so there is a role for prophylactic platelet transfusion in most patients with acute leukemia and those getting transplants. Now, the subgroup that was of some interest in this group are those receiving autologous stem cell transplants, where that signal of excess bleeding did not appear to be the case. So you can see there that bleeding rates, this is WHO 2 and above bleeding rates, were the same between those who were not receiving prophylaxis and those who were. And so this was quite provocative, because you could argue, well, an autologous transplant, which is very common, think about multiple myeloma, perhaps they don't need prophylactic platelets, saves a lot of platelets as well. And I think that some centers have actually taken that to heart and don't necessarily offer prophylactic platelets in autologous transplant patients. I will say that one of the provisos, this was all done as an inpatient, and doing autologous transplants as an outpatient is a different story and is associated with greater risk. What colleagues of mine in Canada are doing right now is they are conducting a randomized trial where they're not offering prophylactic platelet transfusions to autologous transplants, but instead are offering tranexamic acid to these patients. So this is prophylactic platelets when platelets are less than 10, as compared to no platelet transfusions, but tranexamic acid. So this trial is accruing in multiple centers in Canada now. I'm assuming those results will be available in the next 1 to 2 years. It might change practice in the world of autologous transplantation. It doesn't include CAR T patients, though. This is classic transplantation. So just something to look out for. However, while the study is being conducted, there was another important study that looked at the role of tranexamic acid in patients with acute leukemia and transplant. And this came out of 3 centers in the US that conducted a randomized trial whereby all patients received prophylactic platelets below 10, when the counts fell below 10, and were randomized to the addition of tranexamic acid or not to reduce bleeding rates further. And this was a negative study whereby there was no further protection against bleeding by the use of tranexamic acid for those patients whose platelets were in that low range. And so this was a negative study without clear benefit of the addition of tranexamic acid. I will say, though, that there was actually a signal of potential harm here. If you were to look at those who had central venous access line occlusions, did appear to be appreciably higher in those patients receiving tranexamic acid. So tranexamic acid is, I think, of questionable value in these patients and may be associated with some harm. So things pretty much these days stand as they are, that most people with acute leukemia and getting a transplant will need prophylactic platelets when their platelet count is less than 10. Now, not much has changed there over many years. But then what about the risks? So what are the risks of platelets? So here's another question, which your answer will probably vary depending on where you are in the world. But what is the most common cause of transfusion-transmitted infection? So I've kind of stacked this for the Canadian environment, which probably mimics European blood manufacturers and many US manufacturers. Is it HIV, which of course was the classic concern several decades ago? Is it Staphylococcus? Is it Hep C? And is it malaria? Does anyone think it's A or B? Yeah, there's some B's. Any C's? Hep C's? Not so much. What about malaria? A bit more prominent in this part of the world, but not so much. Okay. So I think some of you know the answer already. And so this is just to reinforce that, the classic concern with the administration of platelets has been bacterial infection. This is mostly bacteria from the donor's skin, and sometimes because of transient bacteremia from the donor, for example, after a dental procedure. And of course, complicated by the fact that platelets, as we use them now, are stored at room temperature. And this is a pretty good growth medium for bacteria. So sepsis rates, depending on where you are in the world, are reasonably high. 1 in 125,000 bacterial sepsis. Bacterial contamination of a unit is higher than that. But in terms of bad clinical events, 1 in 125,000, which is, of course, much more common than all of the other infections that I listed there, where HIV is now in the sort of 1 in the 2 to 3 million range. Malaria, similarly, very uncommon, perhaps more common in this part of the world. And Hep C, because of routine testing of donors, is also very rare. So this is significant. And one way around this, those from Europe will know a lot about pathogen inactivation technology, particularly using the photosensitizer ametocillin, or the trade name Intercept technology. This has been recently adapted by all of Canadian Blood Services, so that's why I'm talking about this now. I think for those of you, particularly in mainland Europe, this probably is old news for you because it was adopted by many European blood providers a long time ago, several years ago. And so by adding ametocillin and subjecting platelets to ultraviolet light, provides an additional layer of safety against DNA and RNA containing pathogens, viruses, bacteria, including spirochetes, so that would be syphilis, protozoa, leukocytes, so therefore risks of transfusion-associated graft versus host disease may go down as well. Pretty much the only thing that it doesn't negate are prions. So because of the threat of bacterial infection in platelet transfusions, this has been a big plus. And at least in Canada, this has only been universally introduced for platelet transfusions this year for all forms of platelet transfusions. I think its introduction in the US has been patchy and not at many other blood manufacturers, mostly because there's complicated processes involved and also there's expense involved. It does make the processing more expensive, but a huge safety advantage. And so here are examples of either a pooled platelet product that has been sorrelin treated with this ametocillin, or an apheresis product from a single donor there. They look very similar to regular platelets. And so one of the downsides, though, for you to be aware of, just in terms of being wary of the platelet refractoriness world, is that the way that it's manufactured results in a platelet yield that is somewhat lower to conventional platelet pools or to a platelet apheresis unit, likely because there is unintended loss of platelets during the manufacturing process. And what that means is that the end result, the platelet increment, is somewhat lower as compared to using a regular platelet pool or a regular platelet unit via an apheresis donor. So one's expected unit may be less, and there are now meta-analyses that suggest that if you were to use this pathogen reduction technology, platelet increments during the transplant, etc., is likely going to be somewhat lower than a regular platelet unit. So just to go back to that question, yes, it's Staphylococcus species, but hopefully that will change as the world introduces these technologies to reduce pathogens in platelet products. So let's talk about refractoriness then. I touched on this a moment ago. So if you were to give a unit of platelets, what kind of increment? Well, it's more or less in a clinically stable patient, 20 to 40 times 10 to the 9 per liter. It's an increment of 20 to 40. Strictly speaking, one is meant to be calculating this corrected incremental index, CCI, which is that anything less than 5 to 10 after 2 consecutive transfusions is compatible with refractoriness. And so these are the CCI the corrected count increment is to account for the fact that the recipient has variable body surface area, small recipients, large recipients, and that a given dose of platelets may be different. So this formula accounts for the dose of platelets you're giving and the size of the recipient. Whether you use the actual platelet count or are going to calculate the corrected count increment, it generally is not a one-off thing. You need to at least see it in 2 consecutive transfusions to get the sense that there is refractoriness, there is an issue in this patient. And the vast majority are non-immunologic. They are because of the usual morbidities seen in these patients: fevers, infections, sepsis, bleeding, DIC, the kind of concomitant drugs that are being used in transplant patients. Sometimes patients are coming in with large spleens that cause platelet consumption. But on the immune side, HLA is the big one. And so this is HLA alloimmunization. And unlike the world of hematopoietic transplant, it is primarily antibodies against class 1 HLA and HLA-B antigens that are being formed directed against platelets. I think there is some controversy about the class 1 HLA-C, but predominantly isolated to A and B. Rarely HPA, human platelet antigen antibodies, can be formed as well. There's the possibility of ABO antibodies as well, because platelets do express ABO antigens, albeit weakly. And then there are other rarer causes of antibodies against platelets as well. And don't forget, sometimes when you give platelets, you need to make sure that they're fresh and that they haven't been stored in the wrong way, because that's a pretty classic cause of a non-responsive platelet transfusion. And I'm embarrassed to admit that when I was an intern here in South Africa, in Johannesburg, I was handed some platelets to give to a patient. I think there were 6 bags the days before they were pooled, and I didn't know how to give platelets. And I thought that while I was busy with something else, I would just put them in the fridge on the ward for a while. And then I'd come back to them and give them to the patient. And an astute nurse pointed out that by refrigerating the platelets, I had effectively nullified them. They had degranulated and done their business, and they were useless platelets. So make sure that they've been stored the right way and ready for a patient. That's my little admission of guilt, but at least they didn't go into the patient. So let's talk a little bit about HLA then. So this goes back to the meandering story of my career, but this was one of the projects that I took on actually as a resident when I was in Vancouver, it's 20 years now, where Canadian Blood Services introduced universal leukoreduction of all cellular products. That was predominantly to reduce febrile non-hemolytic transfusion reactions, but there was also a strong feeling that it would reduce platelet HLA alloimmunization, because you were removing white cells that were functioning as antigen-presenting cells to augment that immune response against HLA class 1 on the platelets. And so because this had been a national rollout of leukoreduction, it was a before and after study to say what happened to platelet alloimmunization. And what we found is that HLA alloimmune refractoriness, just with the intervention of leukoreduction, took alloimmune refractoriness down from 14%, which was already better than it had been historically, down to 4%. So not 0. So it still happens. But at least that one intervention 20 years ago made a substantial difference to patients. So why is it still a problem? Why is it still topical? Well, going back to this pathogen inactivation story, there actually is some evidence that when you pathogen reduce these platelets with a photosensitizer and ultraviolet light, paradoxically, and perhaps because you're doing something to the platelets, you're increasing their antigen expression, HLA alloimmunization is going up after the use of these pathogen inactivation technology measures. Not hugely, but a signal that we may be seeing more of this problem in the future. So here's a meta-analysis of clinical trials that were randomized patients between the pathogen reduction technology using the photosensitizer and regular platelets. And one of the downsides, one of the risks, is that it does appear to be an increase. This is the relative risk ratio increase in HLA alloimmune refractoriness of patients receiving the Intercept photosensitizer technology platelets. So this may mean, with large enough experience globally, that there may be more business in the world of HLA matched platelets. And we're keeping a very close eye on this as we've rolled it out. So how do you diagnose immune platelet refractoriness? The most important measure is to look for HLA antibodies. And because we all now live and function in the world of mismatched transplants, either because of haploidentical transplants or these days because of mismatched unrelated donor transplants, I think we all know that donor-specific antibodies, HLA antibodies, are clinically very important, although back in the world of platelets, this has been recognized as very important for many, many, many years. Secondarily, HPA antibodies are also important to look for. And when we're asked this question at Canadian Blood Services, we actually look for both simultaneously to sort of get it done. And we let the clinicians know that we found HLA antibodies, but no HPA antibodies, or vice versa. And so HLA antibody analysis is undertaken in a very similar manner to the way the transplanters would look for it, although we restrict our analysis in these patients only to looking for antibodies against class 1 HLA and B. And so this is a typical readout from the solid phase HLA antibody analysis using mean fluorescent indices to look for the extent and the intensity of HLA antibodies. And here's an example of a patient who had extremely extensive HLA class 1 antibodies with very high MFI levels against a large variety of HLA and B antigens. So this perhaps is one of the more challenging types of patients to handle. And so this is an example of a result. There you can see the patient's HLA type, just restricted to A and B, but tons of antibodies to any other of the HLA A and B antibodies. And this is common in those people who have previously had pregnancies and especially those who've previously been transfused. We've noticed that it's even more noticeable in those who have received non-leukoreduced blood, which is sometimes the case if people have received blood outside of the Canadian jurisdiction. And Canada has plenty of immigrants. Those patients who may have received blood in other parts of the world may not have received leukoreduced blood, which might have augmented the likelihood of developing HLA antibodies. But certainly pregnancy could also do this. And so here's an example of somebody who may be platelet refractoriness and have all of these antibodies. So how do we manage this? For one thing, we can calculate CPRA. So this is a calculated panel reactive antibody, which has been borrowed from the world of solid organ transplant in an attempt to predict the likelihood of having incompatible donors in the population. So this was designed in the kidney transplant world, but this can be reproduced in the world of platelet transfusion world to get some idea of what's the likelihood that this patient, if you were just to give them a random unit of platelets, that they're going to be refractory based on the HLA antibodies that we found. So you plug in those antibodies and it'll give you an answer. And so here, as you might expect with that huge panel of antibodies, the calculated PRA is 99.93%. So you've got a 99.93% chance that the regular donors out there are going to be incompatible from an HLA point of view to the patient. So you've got to find the right patient now. So this is where these precious donors come from. And so we have a panel of wonderful donors in Canada who have volunteered to undergo HLA typing, and they've made themselves available for HLA-specific donations for patients. And so we generate a list of people who are available, and we put in the HLA antibodies that we do not require. So we're avoiding the HLA antigens in these patients, to which we know about the antibodies from the patient's testing. We also look at the age and availability of that donor. And remember, these are very frequent donors, unlike stem cell donors. So we actually have a listing there of when they last donated, because they may have donated so recently that they're not eligible to donate again. In Canada, anyway, our maximum frequency of platelet donors is once every 2 weeks. And so we generate a list to see how many donors are available. Preferably, it would be nice to have a full HLA match at class A and B, but that's not always possible, especially for people who are going to be needing many platelet transfusions. So to give you an idea, in Canada, so around 30 million people, excluding Quebec, which has a different blood manufacturer. And so we have tested around 12,000 blood donors. And of those, on the right side are platelet donors. So we're around about 10,000. And of those, only about just over 3,000 are regular platelet donors. So if you compare it to stem cell registries that require several million donors, worldwide to find the right donor, we have a much smaller pool, in part because our HLA requirements are only based on class 1 and 2, but of course they can also repetitively donate, and some of these amazing donors have donated hundreds of times over the years. They're heroic. Unfortunately, they're also aging, and so they get their morbidities that make it not so easy to donate blood. Anyway, this is a wonderful group of very dedicated people. I will say that one of the challenges is this wonderful group of very dedicated people are predominantly of Caucasian ethnicity. And so as the ethnicities of patients changes, as it is globally, and including in Canada, we may find it more difficult over time to find the right match. As I mentioned before, on the right is the approach we use. So we use antigen avoidance, which is less restrictive than pure HLA matching. And because of that, we have a larger pool of donors. If we wanted a pure HLA match, which is probably the most sensible and safe thing to do, we just have way fewer donors to choose from, and we wouldn't be able to provide platelets on a regular basis to patients. So we've chosen the approach on the right. The downside is that there may be subsequent sensitization to new HLA antigens that patient has not seen before. To give you some idea of the numbers, at least in Canada, so we collect for that population of around 30 million outside of Quebec, around 125,000 platelets a year. So it's a very large program. And around last year, 26,000 or so were apheresis platelets, and then 4,270, so 3.4%, were HLA selected for these special needs. And remember that we only have around 3,000 regular donors, so they're busy, those donors. This all sounds very complicated. Is there any hope for the future? This is my last slide. Just to say, as I mentioned before, in terms of mitigating the problem, widening the donor pool would be great if we had more donors, and especially with greater HLA variety. There are new techniques to mitigate the problem. IVIG and plasmapheresis are not new. You've heard of those. B-cell suppression may ameliorate the problem to some extent, although there's a sense that T cells also play a part here. Anti-complement inhibition using eculizumab is probably the most promising of all of the maneuvers now to get around this. And there is actually a clinical trial open right now using eculizumab for this very subgroup of patients with HLA alloimmunization and platelet refractoriness. So one will need to wait for those results before you can use a drug as complicated, as expensive as eculizumab. IgG cleavage, in other words, really just trying to neutralize circulating IgG with an enzyme derived from strep pyogenes. I don't believe that has become regular practice anywhere else in the world yet, but perhaps in the future. And then really very interestingly is whether class 1 HLA antigen can be completely depleted of platelets altogether using citric acid. Clinical trials are in process there. And even the generation of universal platelets using induced pluripotent stem cells in an attempt to avoid this HLA problem. So that was it. And I hope I was able to give you a very rapid update about platelet transfusions as a very important element to ensuring that transplant and acute leukemia patients get through their procedure well, and that there's more than just stem cell donors to the transplant. There are all of these special other donors, blood donors, and the subgroup of HLA-specific platelet donors that also play a role in the whole transplant process. Just to remind you that there's still a pretty strong role globally for prophylactic platelets in these patients. That you need to think about non-immune causes of refractoriness, and that HLA refractoriness is still an issue despite leukoreduction, and perhaps may become more of an issue now that we're using these pathogen rejection technologies. So I think that was it. Just some colleagues of mine that I work with, Dr. Gupta, who's the lab director, Natasha Rickards, who is the nurse who manages this whole program miraculously, and Dr. Wa, who's a wonderful resident who put together some of these figures that I had shown you. So that's me, and I hope I didn't... Oh, that's Vancouver, by the way, which is probably tells you why I live there. It's quite a pretty place. Thank you.
Well, thank you, Matthew, and also thank you for giving up your duties as the WMDA president.
I got a break.
Which is the most important part of this meeting when we move into the Friday and the Saturday. So thank you very much. Raise some, I know there are going to be a lot of questions. So I think if we can... Oh, sorry, you can't hear me.
Hi.
Apologies for that. I'm going to ask them to bring some mics out, because if you have any questions for Matthew, he'll be seated on the panel now, or for any of the speakers that have been in this session. And I will then thank them, and we have a little gift for each speaker here. But if you can, come up with any questions. I think there's one at the back.
It's me. Okay, yeah. Thank you very much for the very enlightening speech. My name is Kalinga Pera. I'm from Welsh Bone Marrow Donor Registry and from the Welsh Blood Service. In the UK, what we use to provide HLA-selected platelet, the usual indications are the patient with refractoriness, obviously, and also the patients with platelet function disorders, mainly Glanzmann and the Bernard-Sollier, and we are not very restrictive about the other platelet function disorders as well. Recently, we have been seeing some transplant centers requesting HLA-selected platelets for mismatched transplants and haploidentical, and also for the patients who already has got antibodies. So far, my colleagues of the other blood services of the UK also been telling that it is, at present, it's not possible because of our the resource impactness. So my question is have you had any health economic analysis of this approach? Because I saw that it needs much of a resource allocation for you to provide the HLA-selected platelets for this cohort, with the haploidentical and the mismatched transplant going up pretty much. Thank you.
Yeah, so that's such a wonderful question. So what you're asking about is special platelet support for those patients receiving HLA mismatched transplants, whether it's a family haploidentical transplant or a mismatched unrelated, and whether they need any special peri-transplant care. I'm aware that there are some serious experts in the world of mismatched unrelated transplant in the room, so Dr. Devine and Dr. Shaw, you're welcome to put your hands up here. We have had very similar requests to say, well, we're doing a mismatched transplant. Please could you ensure that you're giving us HLA-matched platelets in the peri-transplant period, because the last thing we want is new donor-specific antibodies and rejection of the incoming cells. So we looked this up in terms of, well, are there publications to support this? And I'm not aware that there are any publications to support this. In other words, prophylactic HLA matching in the peri-transplant period as an additional support to a good outcome of a mismatched unrelated transplant. However, the absence of evidence doesn't mean that we haven't tried. We actually have tried. If they've painted a good enough picture to say, well, the last thing we need is new donor-specific antibodies. So where possible, we've looked at the HLA characteristics of the recipient and the donor, and we've tried our best at least to be antigen avoidant with our donors to avoid any current donor-specific antibodies and to avoid any that might cause new HLA antibodies. And where possible, we've actually tried to use, in the peri-transplant period, an HLA match to the incoming donor cells at the class 1 level. But I can't say that there's evidence to it, to support it, and sometimes we just simply haven't been able to because we've had insufficient donor capacity for that. But if there are others in the audience who want to talk about that, please go ahead, because it's an area of uncertainty for sure. Perhaps Tanya may know as well, but great question. It probably needs at least a case series, if not a clinical trial, or at least a secondary analysis of existing clinical trials and mismatched unrelateds.
Matt, I don't have a comment on that, but I have a question for you and one for Rachel. Andrew McDonald from Pretoria. So to Matt, use of TPO mimetics, do they do anything in the setting of a planned transplant and limiting platelet usage? And then to Rachel, just in terms of the serious adverse events, in terms of have you looked at donor, how it impacts donors in terms of just the feelings about donations and just spreading a word that this is not such a good thing to do?
So Andrew, maybe I'll quickly answer, because mine's the easier one, is that I'm not aware of any evidence that TPO mimetics would be helpful in that respect. You're obviously potentially driving the production of more platelets, but mature platelets will simply be destroyed in the process from the circulating HLA antibodies or by T-cell mediated means. So I certainly haven't seen it in practice, and because we have so many requests about what to do about big, troubled patients, that I didn't see any published evidence to support that when the refractoriness is alloimmune.
And I'm not sure my question is harder, because we don't get information on donor mental health after, as in SPEAR reports routinely. Well, I mean, we have had a report of a donor who committed suicide, but that was quite some time after the donation without any clear link to having been a stem cell donor. I mean, Megan, Cody and the medical committee have got a project ongoing at the moment looking at donor mental health, and I think it more feeds into how you follow up donors and the support you offer them, but it's a very good question. Thank you. While I've got the microphone, can I ask Matthew a question? Thank you. Do you think red cell transfusion is any part of HLA alloimmunization in transplant patients? And we know in the renal transplant community there is concern about triggering acute rejection potentially because of red cell transfusions, and some pilot studies of trying to match red cells for kidney transplant patients.
So yes, I mean, I agree. Red cells are leukoreduced universally. Certainly in your part of the world and my part of the world, they are. But I don't think that it completely reduces that risk. And so, yes, I think that preceding red cell transfusion support is likely an additional factor there. And I am aware, yes, I think there is even a randomized controlled trial in the kidney transplant world of HLA-matched red cell transfusions in the solid organ world. And is that in the UK? I think it's in the UK. But other than I'm aware of the risk, I can't say much more than that.
It looks like everybody wants to get to tea.
Yeah.
So I just want to thank our speakers, coming out, being here, sharing your knowledge